Hi, Marcelo, can you hear me?
Yes. Can you hear us? Can you try again?
Yeah, perfect. So grab the microphone so we can get the answers about what category you want quickly, and let's try to go through the entire Jeopardy. All right, guys. So welcome to Jeopardy. So the last Jeopardy we had over at the antibiotic one was very unfair for St. Luke's. Just saying. Just saying. That was horrible. Yeah. I was there, but the guy, every time he asked a question, like we had a bunch of guys trying to answer, and he would give the question to you. So, unfair. Not good. Very unfair. All right, this one is, we follow our same rules. This one is better. All right, so let's start. All right, today's categories are HIV 101, tick-borne infections, syphilis, neutropenic fever, fungal infections, and history of medicine, as always. I have to say the funny names for the categories, we only get that when Valeria is here. I can't come up with those names. Sorry for that. All right. So since West is gonna win today, let's give the first opportunity to St. Luke's. All right, guys, you get to choose the first category.
Neutropenic fever for 500.
All right, so neutropenic fever for 500. So it says, what is an acceptable initial empiric antibiotic regimen for hospitalized patients with fever and neutropenia without a clear infectious syndrome? You have 5 seconds. 5 seconds.
Zosys. Cefepime.
Okay, so cefepime is fine. Can you expand a little bit more? What are just the principles?
And Flagyl.
No, you got in trouble already. You got in trouble already. All right, just the principles of treating patients with fever and neutropenia with no clear infectious syndrome. I'm going to give you 2 seconds to try again.
Cover gram-negatives.
Okay, so gram-negative.
Yeah,
How?
the most common infection source is from the GI tract.
I'm sorry?
Most common source is the GI tract. So
Okay, so, but tell me more.
So that's why Flagyl was for the anaerobics. And so the monos is definitely in the gram-negative. So yeah. That's
all right, so but
well.
you're not giving me the principles that I want. All right, so let's give Wes the opportunity. Grab the microphone.
Take it. Okay. Just say.
Just cefepime.
Oh, okay.
Yeah.
So because you don't have neutrophils, you are going to have translocation, and because you are giving chemotherapy, you are going to have destruction of the virus.
That's too many words, Christian. That's like, give me the principles. What do you need?
So we need, yes, anti-pseudomonal coverage, gram-negative coverage.
All right, so.
We said that.
But the difference is...
Right, so the word that I'm looking for is the word that is written in the guidelines and in UpToDate if you read it, which is monotherapy with gram-negative coverage, including anti-pseudomonal coverage. That's what you need to say. Because it is a common mistake to use really broad spectrum antibiotics, including gram-positive coverage, such as vancomycin, and that is a common mistake. So the right answer is monotherapy with an anti-pseudomonal agent. For example, for the inpatients, cefepime is an acceptable option, but you can also use ceftazidime, zosyn, or a carbapenem. If you have a patient who has an allergy to penicillin, it wasn't clear to me. And Flagyl is not correct. So
there's a problem with the transmission.
Right, so penicillin allergies, you treat those patients with Astronam plus vancomycin or Cipro plus clindamycin. So that's the only sort of like scenario where you have to use vancomycin. But for the rest of the patients, you use monotherapy with cefepime, ceftazidime dosing of or carbapenem. All right, so who's keeping the score? Is Marcelo or Avinash? Okay, so Avinash is keeping
Marcelo's
the
doing
score. Marcelo, okay. So Marcelo, I'm not gonna, this is a must know 100% thing, so I'm not giving the score to anyone. Just to be all or nothing. All right, so West,
Okay, same for both sides, okay?
yeah.
Fungal infections for
All right, so fungal infections for 500, the rule here is that Christian cannot participate, all right? All right. So you see, Marcelo, I'm being fair. All right, so this is the daily double. All right, so describe the clinical syndromes associated with blastomycosis. So, and I want pretty much everything you can say about it. Clinical syndromes. So,
Can we just tell you what we know?
yeah, of
5
course.
seconds, right?
So the first thing, like for all the endemic fungal infections, you can get acute pulmonary infection, which presents like a flu-like infection or syndrome. And then that can progress to chronic pulmonary syndrome. And then you can have disseminated blastomycosis. And that classically can affect, number one, the skin, followed by bones. When it involves the skin, it usually causes like verruca or like some sort of skin lesions, ulcerating or nodules.
Okay.
And classically also second cause can affect the bones, like the second most common.
So that's very good. That's a really good answer. So I'm happy with that. So the only thing that I would add to that is that remember 50% of the patients can be asymptomatic, and out of the 50% who are symptomatic, all of those syndromes are described. I just put here one of Christian's slides. So again, 50% asymptomatic, 50% symptomatic, pulmonary syndrome is 90%, acute or chronic, as you said, and disseminated is 25 to 40% of the ones that are symptomatic, and skin and bone are sort of like the most commonly seen. So very good, very good. That's 1,000 points. All right, St. Luke's. So Critical wants you to get history of medicine.
They want HIV 500.
HIV 500. Okay, let's go. So, okay, so the following are commonly used drugs in HIV patients that you will frequently encounter as a PCP or a hospital. This is a most known to. So mention one side effect for each one, and it cannot be GI side effect, right? So let's start with TDF, tenofovir disoproxil fumarate. Tell us one side effect. 5 seconds. So you have to say one side effect for each one.
So, TDF. The old tenofovir, you can see osteoporosis. Then we're going to go one by one.
Okay, so how about dolutegravir?
Nightmares for dyslipidemia for
I'm sorry?
dolutegravir.
So dolutegravir.
for
What is
Yes.
the one thing that you have to be concerned about with dolutegravir? All right, so we go to atazanavir. What is the one thing you have to be concerned about with atazanavir? If you know something about the rest, just jump in and say it. For example, for abacavir or ritonavir boosted PIs or efavirenz, tell us what you know. I give you 5 seconds and I'm gonna transition to West.
Hypersensitivity reaction
For who, for what?
to abacavir.
Okay, that's correct. Okay, how about the others? All right, so West. You guys get the chance. Let's start with
Efavirenz, bad dreams,
okay, that's
and
correct. Bad dreams, that's correct.
ritonavir, I would say hyperlipidemia, hyperglycemia. So basically,
Okay, so
yeah.
that's good. Metabolic side effects. Okay. So we're still missing dolutegravir and atazanavir. Yeah. All right. So West, dolutegravir.
Teratogenic and
Teratogenic, atazanavir, neuropathy.
Also for atazanavir, it causes benign jaundice. Like
Okay, so dolutegravir, definitely teratogenicity is the one thing that you need to know because it's not an acceptable drug for patients of childbearing age or pregnant patients. So that you need to know. Atazanavir, the ones that you mentioned also perfect, but AKI is also one that is important and is not, for example, TDF and atazanavir are two of the drugs that you shouldn't be given to patients with AKI or compromised kidney function. The rest of the side effects that you guys mentioned at St. Luke's are perfect. I would add for TDF, it's not only osteoporosis, also Fanconi syndrome. So proximal tubule dysfunction is one that you must know. Okay? So let's repeat. For TDF, Fanconi, and osteoporosis, for dolutegravir, teratogenicity, for atazanavir, neuropathy, AKI, are ones that you need to know. Abacavir, definitely hypersensitivity reactions. That's why you need to send your HLA B5701. For ritonavir booster PIs, your increased cardiovascular risk because of the metabolic side effects, you need to add that. And efavirenz, the bad dreams, vivid dreams, bad dreams. Okay, that's good. So out of 2, 4, 6, I got 4 that were correctly answered by St. Luke's and 2 by West. So now 2/3 to St. Luke's and 1/3 to West.
300 to St. Luke's, 200 to West.
All right, so sounds good, Marcelo?
Wasn't it 1 for West, dolutegravir?
They said dolutegravir and atazanavir. So they got 1/3 of the answer. So 1/3 and 2/3. All right, so West.
Tick-borne 500. Tick-borne infections 500.
Okay, so tick-borne infections 500. All right, so this is a patient from New England. It's very easy. Patient from New England presenting with fever, chills, mild anemia, and elevated LDH and bilirubin. So you see this peripheral smear. So what's the diagnosis?
Babesia.
Okay, Babesia, that's correct. Very good. And essentially it looks like malaria, right? Very good. Sorry, Lux. That's it. You got the 500. All right, Lux.
Syphilis for 500.
Okay, syphilis 500. All right, so when should an LP be performed to rule out neurosyphilis in a patient known to have syphilis? How do you establish a diagnosis of neurosyphilis? So 2 questions in one. This is a must-know thing for all primary care doctors too and internists. 5 seconds.
Okay. So if I remember Dr. Pfeffer's talk, he said throughout neurosyphilis, if you really know he has syphilis, you need to make sure if the RPR is going up or if he has any symptoms. Also, if you're suspecting otologic or ophthalmologic syphilis, you have to rule out with an LP. And usually you have to do the diagnosis with an LP, and you can do RPR
How do you establish the diagnosis of neurosyphilis?
So if you have a positive, so neurosyphilis can be acute or chronic, like Dr. Pfeffer said. If you have someone presenting with acute syphilis, like a primary syphilis with neural symptoms, you have to suspect neurosyphilis and you diagnose with CSF. You can do treponemal test or RPR in the CSF.
I agree with that, but now the question is, you have a patient that you suspect neurosyphilis, you do an LP. So what do you do to establish the diagnosis? And it is a kind of a tricky question. So because if you suspect neurosyphilis and I do an LP and the CSF is clean, meaning no nothing, zero WBCs, then the patient doesn't have neurosyphilis, right? So how do you establish the diagnosis? That's the question.
You don't do serologies then?
So what's that leads to another question. What's the sensitivity of, for example, a BDRL in the CSF?
So VDRL is not sensitive. So usually you don't do VDRLs on, but you can do FTA, like treponemal tests on the CSF in addition to dark microscopy.
You're just getting yourself in the wrong path. No, you definitely do VDRL or RPR in the CSF. Now the problem is that you do not establish diagnosis based on that only because the sensitivity is low, right? So what do you need?
Is it Treponema pallidum antibody index?
No. All right, so West, what do you guys think? So let's start with one thing. So the first answer that David gave was correct. So we no longer do LPs on all patients with primary syphilis or early syphilis. That's not recommended anymore. So in any patient with syphilis at any stage who presents with possible symptoms of neurosyphilis, otologic syphilis, or ophthalmologic syphilis, you do an LP. So that answer is correct. Now, the second question is the one that I haven't gotten the right answer. So how do you establish the diagnosis of neurosyphilis? It's simpler than you think.
Show rising titers?
No, so yeah, so you guys didn't get, so I'm gonna give the answer. So what you need is, number one, you need a compatible clinical picture, and you need pleocytosis of the CSF. That's the only thing you need. None of the treponemal or not treponemal tests are sensitive enough. No, I didn't say that. I've said that if cells are zero, the patient doesn't have neurosyphilis. So I kind of gave away the answer. So the idea is that if you have a compatible clinical picture and you know an LP, and the LP has CSF pleocytosis, that is enough. So it's usually lymphocytic, yeah, lymphocytic pleocytosis. But again, the tricky part here, and it's important for you guys to understand, is that what is usually used in the CSF is BDRL. The sensitivity of BDRL is 50 to 70% only. So if you have a patient that has, let's say, a positive RPR with high titer and has a uveitis, so ocular syphilis, and you do an LP and has 50 WBCs with 90% lymphocytes but a negative VDRL, it doesn't matter. That patient has neurosyphilis and should be treated as a neurosyphilis. That is a broad question, and it is very important for daily practice. You need to know that, okay? All right, so very good. So I'm gonna give 50% of the points to Lux. West.
No.
So then let me say again what I say every time. History of medicine questions are easy this time.
No.
It's true that they're easy.
Okay, history.
You want? All right, so history of medicine 500. And actually, you got the easiest question of history of medicine. If you don't answer this, all right. So this photo shows a white doctor drawing blood from an African-American patient who was a subject in this infamous study conducted from 1932 to 1972 with funds from the US government.
Tuskegee.
Tuskegee study, that's correct. You guys know, you see? Is that?
Free $500.
All right, so this is we always say about, how good it is to know about history of medicine. There are certain things in the history of medicine that you must know. And this is one of them, because this was a very important thing that actually after the outcry in the 1970s, when this was made public, it led to the Belmont conference and the creation of IRBs and all of this stuff that we do right now. So this is a most known thing in the history of medicine. Okay, Lux. Marcelo, your team is slow.
History of medicine for 400.
All right. History of medicine 400, I like it. So this is also a most known thing, and it's kind of like related. So this infamous study was conducted in Guatemala between 1946 and 1948 with funds from the NIH and led by Dr. John Charles Cutler with the consent of the U.S. Surgeon General. This is an infamous study that also needs to be known. We don't have any residents from Guatemala anymore. We used to have one 4 years ago. Oh, we have, oh, right, that's true. Well, that's true, that's true. What is Bertin?
Bertin is off today.
All right, so you guys have 5 seconds. All right, anyone at West? Okay, you're passing. So I'm going to tell you, this is a very interesting part of the history of syphilis. The study was called the Guatemala Syphilis Experiment. This actually was much worse than the Tuskegee study, and it was conducted by the same people. So what they did is that they went to Guatemala and they recruited people in the military and farmers, and they inoculated syphilis and gonorrhea to people randomly. 50% of them were treated and 50% were not. Around 80 people died as a consequence of that. In the 1990s, the US government officially recognized this and apologized. President Clinton did, and it led to an active lawsuit from the Guatemalan government to the US government. So this is also another very infamous study that we all should know.
It's still, the case is still active in the US court.
All right, so I think it's West now, West.
Fungal infections 400.
Fungal infections 400. Nice, all right. So this is a most known also from Christian's lecture. Christian, you can talk, you cannot talk. So coccidioideal meningitis has approximately 95% mortality at 2 years if left untreated. So what is the first line antifungal used to treat it and for how long?
Lifelong fluconazole.
Okay, that's correct. So lifelong fluconazole. And remember what Christian mentioned in his lecture is like, if you're a PCP, you have a patient that had coccidioideal meningitis and is taking fluconazole, please do not stop it. Okay, for life. Good. San Lux.
Neutropenic fever for 400.
All right, so neutropenic fever for 400. So patients with fever and neutropenia should be reassessed frequently as needed. A formal reassessment, though, should happen after 2 to 4 days of therapy. How do you approach management according to this assessment? And I want it kind of like in an algorithmic way. What do you do? That's for San Lux.
Is the patient still febrile? Are the blood cultures growing anything? I think we'll start with that. Yeah.
Okay, so let's say that that's one direction. But how do you go algorithmically? So I'm going to give you a few possibilities. So the same patient who was stable initially is still stable, and the cultures are not growing anything, but it's still neutropenic. What do you do with that patient?
Is the patient still febrile or no?
The patient is still febrile.
We'll continue the same antibiotics.
Okay, that's correct. You continue the same antibiotics and reassess afterwards. So let me give you another possibility. So the same patient who is no longer having fevers, but is still neutropenic, what do you do?
And cultures are not growing anything.
Cultures are not growing anything.
And it's 4 days. So usually we treat it for 5 to 7 days. So we can either discontinue the antibiotics and monitor the patient. I mean, we can discontinue the antibiotics and monitor the patient in hospital for another 24 hours to see if he spikes any fevers, or continue them for 5 days and then stop it and discharge him.
So the reason I'm going to give you that is that, so there's a difference between what the guidelines say and what some of the most recent studies have showed. The most recent studies have showed that if the patient was low risk, the patient did fevers already, and even if the patient is still neutropenic, you can probably treat for 1 or 2 days after the patient defibers and stop antibiotics. Now, the guidelines say treat for 5 to 7 days or until the patient is no longer neutropenic, right? So I'll give you the answer for that. So let's give you another possibility. So the same patient now, after 3 days of therapy, is getting worse and is in septic shock. What do you do with that patient?
I mean, yeah, if the patient is in septic shock, we have to activate the sepsis code, or like treat for fluid resuscitation and then broaden the antibiotics. Basically, if we are giving Zosyn and Vanc, think about ESBL and switching the Zosyn to carbapenems.
Oh, remember that we weren't given Vanc from the beginning, right? Because you're not supposed to.
Oh.
Let's say I'm fine with the Zosyn, but at this point in time, if the patient is getting worse and is getting into septic shock, then you need to broaden antibiotics. So it is reasonable to add MRSA coverage, and you should consider antifungal. You don't have to empirically, but you should consider it. And at that time, you should be very aggressive in testing also. But this patient probably gets to get the scan from everywhere, needs to get culture from everywhere. So that's the idea at that point, all right?
Yeah.
So, good, let's leave it in that. But the idea is that you guys have to have some sort of algorithm in your mind. 2 to 4 days after therapy, you reassess your patient. Is the patient doing fine, no longer having fevers, is low risk? You need to know what you do in that case. Is the patient still having fevers, but is low risk? Know that the average time to defervescence for this patient is around 5 days. So it is acceptable to continue the same antibiotic regimen. However, if your patient is deteriorating, is in septic shock, then you need to broaden and consider opportunistic infections, such as fungal infection, things of that sort. All right, good. There is actually a very nice algorithm in UpToDate that you can sort of like look for it. Study, I'm going to give you the points. West.
HIV 400.
All right, HIV 400.
HIV 400.
All right, so it says, when should ART be started? And what should be considered before starting a patient ART? All right, you got 3 seconds to answer that. It's your base.
When the patient is agreeing, or ASAP.
All right.
When the patient agrees.
So I think that's a very good answer. So when the patient is ready, as soon as possible. Very good. So what should you consider before starting ART? Okay, get the microphone. Get the
Sensitivity testing.
Geno or phenotype? Genotype or phenotype?
Speak on the microphone.
Both. But mostly genotype, I think.
All right, so you should send the genotype. I agree, but that shouldn't stop you from starting empirically, right? So what else? Very good. So you look at if the patient has co-infections, including Hep B, Hep C. What else? What should that be? Because there's only one. All right, so speak on the microphone, Christian, because that's important.
Okay, so CNS infections like crypto meningitis or tuberculosis meningitis, if you start these patients on antiretroviral therapy and you give them ART, they are going to develop immune reconstitution syndrome, so they will die of the virus.
Okay, so very good. So it's a good thing. Remember, a long time ago, iris was a main concern for these patients, and we didn't start ART for most patients who had opportunistic infections. Now we know that for most opportunistic infections, you can just start IRT and it doesn't matter, with the exception of CNS space-occupying lesions due to infections. The main one, the classical one, is cryptomeningitis, okay? So in those patients, you do not start IRT right away. So what other things you should consider before starting ART? Is the patient pregnant? Very good. Kidney and liver function, very good. What else?
Lipids.
So lipids and comorbidities, right? Because you may want to make sure that if the patient has super high cardiovascular risk factor, something like that, you don't start, ritonavir boosted PI. So the idea is that you look at all the things that would help you tailor the therapy for that patient. Okay, so good. You guys get the point. St. Luke's.
Tick-borne for 400.
All right, tick-borne infections for 100. So describe the epidemiology, vector, and clinical manifestations of Rocky Mountain spotted fever. So you need to give us the epidemiology. So, and the only thing I want from epidemiology is the geographic distribution. You need to tell me which vector, and you need to give me the clinical manifestations of it.
What's the name of the vector? You can answer. The big one, the big vector. Okay.
So the vector is the Syphilis. And
I'm sorry?
the vector is the Syphilis.
No.
Okay.
No.
Yeah.
So keep on going, keep on going.
It starts on the extremities and then it goes central.
I'm sorry?
It's, yeah. It starts on the extremities and then it goes towards the center of the body.
All right, so you're talking about the rash, but what
Yeah,
else?
sorry. Fever.
Okay. Fevers, what else?
Headache.
Headaches, very good, okay.
And it's found in the Rocky Mountains, Colorado. No,
You were fine.
it's not,
Okay.
it's not. It's in the southeast. It's not found in the Rocky Mountains. It's a misnomer.
All right, so I was so Rocky. First of all, Rocky Mountain spotted fever is in the entire United States. That's the right answer. So mountain Rocky Mountain is a misnomer. It's everywhere, right? So that's one thing. So the clinical manifestations, you're right. So pretty much fever, malaise, myalgia, rash, which is not in 100% of the cases, but as you mentioned, is one of the hallmarks of the disease and usually affects the palms and soles. And they can have also meningitis symptoms, you're right. And the vector is actually dermacenter, mainly dermacenter. There are others, ticks that can transmit it, but it's mainly dermacenter here. So I'll give you the points. You get it, most of it. I'm being good with St. Luke's today.
Syphilis.
All right, West.
Syphilis 400.
All right, syphilis 400. So how do you monitor patients after treatment for syphilis? So what is considered appropriate response and what is set of fast state? Get the microphone, people at Lux can hear you, and then they will think I'm cheating.
So, I don't know what is serophas. Do you know what is serophas?
Can you stand up?
I will say this is also a very important thing for primary care internists. So this is an all of nothing. You have to tell me everything.
Okay, we know the first two, but not somebody knows the third one.
You can make it up. We can make it up.
We can make it up? Okay, let's make it up.
Okay.
So how do you monitor patients after treatment for syphilis? So the treponemic tests, they will always be positive, so you need to follow the non-treponemic tests. They need to be the quantitative VDRL, and appropriate response is if the titers go below four times.
Okay, so fourfold decrease in the titers.
Yes,
Okay.
4 times decrease in the titers, and I imagine that sero-fast state is somebody that kind of changed serologically really fast, but
No, anyone that looks have the answer for that?
yes, I don't know the third one. I don't know what is the third one.
All right, so no one is going to get this one because you need to know this. So, so how do you monitor with non-treponemal tests? You're right. You do it at 6 and 12 months for people who had pretty much like early syphilis. For people with late syphilis, stuff like that, you can extend it to up to 6, 12, and 24 months because they can sort of like take a little bit longer to decrease the titers. For people with HIV and syphilis, you need to do it more frequently, usually 3, 6, 12 months. So appropriate response is a 4-fold decrease in the titer. For example, if you have an RPR titer of 1 in 32, a 4-fold would be 1 in 8. Good. So the set of fast states.
Hello? Wait. Can I guess?
No,
The
guys,
serofast
you had time to look it up in UpToDate. All right, so the set of fast state is when you treat someone had an appropriate response, so the titer decreased by 4-fold, but it doesn't get to normal. So let's say it persists as a positive RPR titer, despite having an initial appropriate response. That's set of fast state. So most of the time that means nothing, so you can just follow these patients. If the titer increases again or something like that, then it's another point. But know that there's a percentage of patients that would remain positive. That's set of fast. So no one gets the points here. All right, Lux.
Tick-borne 300.
Tick-borne 300. All right, so describe the epidemiology and vector of infections due to Ehrlichia jaffensis and Anaplasma phagocytophilum in the US. So just give us the geographic distribution and what vector causes these, transmits these diseases. This is it. All right.
Okay. So the
Uh-huh.
vector, I think, for both of them is the Ixodes tick, and babesiosis is like the anaplasma one. Ehrlichia, I think, is Lyme. And then epidemiology, like location, is that?
Uh-huh. Yeah, geographic distribution.
Like the Mississippi and Ohio River valleys, maybe? Or no, I think like the East Coast, Northeast. The Northeast is final.
For which one?
Sorry?
For which one?
Oh, for Ehrlichia is the Northeast, and then Anaplasma is like Northeast and Midwest.
It's not exactly. So
Close.
anyone here at West wants to try? No? So I'll give you, so first of all, they're not transmitted by the same tick. There's a difference. So first of all, for Anaplasma, it is Ixodes scapularis. For Ehrlichia is Amblyoma americanum. So essentially for Anaplasma is the same geographic distribution as Lyme's disease because it's the same tick and there's a lot of them have co-infection. For Ehrlichia jaffensis is a wider distribution. Classically, when you read, they said in the south central and southeastern states. But important to know is that it's a different tick. Right? It's not the same. Right? The one that you probably need to know the most is probably anaplasma because it is it's transmitted by the same tick as Lyme disease, so you can get co-infection. Okay. Good. West. Fungal infections 300. Right, so in a patient with significant cellular immunosuppression of any etiology presenting with molluscum-like skin lesions, what are never misdiagnoses to be considered from the ID standpoint?
So you mean what can it be caused by?
Yeah, so tell me
things.
3 things that you
Yeah.
cannot miss in these patients.
So histoplasmosis,
Okay.
coccidiomycosis. No, sorry, not coccidiomycosis. Talaromycosis, I think.
Talaromycosis, okay.
And the last one is penicillosis is the same one. Crypto. Yeah.
Okay.
Cryptococcus.
Cryptococcus. Okay, so those are the 3. Let me repeat it. Histo, crypto, and talaromycosis. Okay, those are the 3. Remember Christian lecture about that. Very good. All right, St. Luke's.
History of medicine 300.
All right, so very good. History of medicine 300. I like it. So tell us what the Terre-Haute prison experiments were.
About syphilis?
They included some syphilis, but it's not the only thing. But just tell me what they did and what was it all about.
They injected patients and then watched them over time.
It follows a pattern, right? Is anyone a West? No. So this is another. Good up, tell us.
So this was like an artificial cohort kind of experiments done on the African American population in which they were not treated for syphilis, even though they were diagnosed, just to see the long term.
They're confusing this with the Tuskegee study, what we already gave. So it's not that one. So
you get negative points for saying that.
So this is another infamous study that you guys need to know. So again, it was conducted by the same guy, this John Kotler, the same guy that was a co-principal investigator in the Tuskegee study and was the principal investigator in the Guatemala experiments. So it was conducted between 1943 and 1944, where they actually inoculated venereal diseases to sort of like prison mates in this prison in, I think it was Alabama or something like that, Indiana, the Terre-Haute prison. And the difference between this study and the other ones is that they actually consented these people. Now, there is a reason why when you submit something to IRB, you have to say explicitly if you are including vulnerable population. And among the vulnerable population, inmates are considered. Because what they did is that they said, okay, we're going to do this to you, and then we're going to give you treatment. However, if you do it, we're going to write a letter to the judge to be considered in case you are sort of like set free before your expected time in prison. And you're also going to be paid $100 for this study. And you're also going to be placed in a nicer location within the prison. So they did all of that. So they consented the guys, but they essentially told them that we were going to give you all of these if you participate. So that's why, as a result of this study, when you're submitting an IRB, you need to say if you're considering vulnerable population, and inmates are considered among those. It also includes children and other people. All right, but this is another study that you need to know. All right, so West. Neutropenic fever 300. All right, so describe the initial management of patients with neutropenic fever. Patients, there's a, so algorithmically, what do you do? What do you do? Get the microphone.
No,
So that may give you the thing, so you tell me what you do. So the patient, this is a patient with cancer who is on chemotherapy and shows up at the door of the ED with fever.
Okay.
Too many cues.
I'm just, the same thing I did with Stuti.
Be fair, Marcelo. So the most important thing is that this is time sensitive. The patient should get antibiotics. You should not delay the antibiotics. We already talked about this. So gram-negative with anti-pseudomonal coverage if the patient doesn't have any risk factor to get like gram-positive bacteria. So cefepime as soon as possible. After that, you do like the rest of the stuff. So
what do you do?
Blood cultures, your full set of labs, CBC, BMP, liver function tests, chest X-ray. Only if the patient has respiratory symptoms.
Okay.
UA.
All right, and then with all of that and your clinical assessment, what do you do?
So you need to calculate if the patient is high risk or low risk.
Okay, so you do risk assessment, right?
Mass.
Okay. You can use the mass score, and what else?
That's the only one that I know. You know the other one?
Another one called the CISNE score, but that's fine. You don't necessarily need to use it. The idea is that you re-stratify your patients. If your patient is very low risk, what can you do with that patient?
Yes, the patient can go with levofloxacin home.
Can go with oral antibiotics. Can go home with oral antibiotics. If the patient is intermediate or high risk, or the patient has any of a long list of syndromes,
any patient needs
inpatient.
Yes.
Okay, so very good. So the things that I want you to say when this answer is, number one is that
antibiotics.
Giving antibiotics and evaluating for sepsis is time sensitive. If the patient is septic, you treat a sepsis, including everything you do in sepsis. The antibiotics should be given within 1 hour of the patient showing up in the ED. Okay? You do all the tests that you mentioned, and after that, you do risk assessment. That's what I want. Okay, very good. And this is an algorithm that is up to date, it's very nice, and it gives you what you need to do within 1 hour. All right. San Luke's.
HIV or 300.
Okay, HIV 300. All right, so it says, explain the life cycle of HIV virus, including all the enzymes and proteins used by the virus that are therapeutic targets.
Okay, so it has two surface proteins. There's like a CCR5 and another one. What is it? There's P24, but it uses two other ones to get into the cell. It also uses reverse transcriptase to like put itself into your DNA. It uses integrases and proteases and maybe helicases to like unwind the DNA and then insert itself in with reverse transcriptase. So some of the medications are reverse transcriptase inhibitors, and they're nucleoside ones and non-nucleoside ones. And then there's also protease inhibitors, so it can't cut the DNA to insert itself into your DNA.
All right, so I'm just going to organize it a little bit. You did mention all the enzymes and proteins, but what they did is kind of a little mess, but I'll give you the points. Let's see. So number one, the virus has to enter the cell, right? For that, we have entry inhibitors. CCR5 is actually a host protein. It's not a virus protein, but I'll give you that. Then once the virus is inside the cell, it needs to, remember, HIV is a retrovirus, right? So it has RNA. So it needs to convert that to DNA. And for that, it uses reverse transcriptase, right? Then that DNA needs to enter the nucleus of the cell and integrate to the host cell DNA. For that, it uses integrase. Then the virus uses the host cell machinery to sort of like produce its proteins, DNA, whatever. And then after all the proteins for the virus are formed, it needs to assemble and leave the cell. Before the assembly, it needs to break down a very long protein that it has formed before. And for that, it uses protease. And then it leaves the cell. So all of those are the enzymes and proteins that the virus has that are target for therapy. I'll give you the points. That's good. That's fine. I only wanted the ones that are therapeutic targets. Okay, West. Syphilis 300. Okay, so describe clinical syndromes associated with neurosyphilis.
We said it.
So grab the microphone and you need to tell me all of them.
Why me?
Yeah.
Davis dorsalis, Davis dorsalis.
Say it in the microphone.
Tabes dorsalis.
Okay, so get tabes dorsalis. What else can you get?
Meningovascular.
You can get meningovascular syphilis. What else?
Ocular syphilis.
You can get ocular syphilis. Okay.
Otic.
Okay, otologic syphilis. What else? What do you mean with everything?
Generalized paresis of insane.
So general paresis is one syndrome described, but what does it mean? Dementia, that's correct. Okay. What else? You're missing one thing. That's part of the, yeah, Arjen Robinson pupils are like part of the, it's part of the general paresis syndrome, actually, most patients have. But there's one thing that is actually very common, right?
Meningitis.
Yeah, so acute meningitis. That's so you can get, remember, so the one thing that I want you to take from here, especially for the medical students, is that neurosyphilis is not tertiary syphilis, right? Neurosyphilis can present at any stage of syphilis. During early syphilis, usually you get asymptomatic meningitis, symptomatic meningitis, meningovascular syphilis, that the common presentation is just a stroke in a young guy. Then in the late stages of syphilis, you get Tabes dorsalis, you get general paresis. You can also get gomas inside the brain and have like a space occupying sort of like symptoms related to that. Okay? But you definitely need to know all of those syndromes because that's classic medicine. Good. All right. Lux.
History of medicine 200.
All right, I like it. History of medicine 200. These are a little bit more, a little bit more kind of difficult. So this French physician, he won the Nobel Prize in Physiology and Medicine in 1907. He discovered that protozoa actually cause diseases. And the first one that he described was a protozoa that he called Oscillaria that caused malaria. He also worked in trypanosoma, was one of the first guys that described sort of like trypanosoma cruzi, not trypanosoma cruzi, so the African trypanosomiasis. So who is this guy?
Bernard.
No. So, all right, anyone else? Well, who?
Pasteur.
No. Anyone else? No. So this guy is Alphonse Laveran. Charles Alphonse Laveran. Laveran is it's actually the guy that discovered protozoa, guys. We need to know that guy. Okay? All right, West. Fungal infections, 200. So chest medicine clinical syndromes associated with histoplasmosis. I like this one. I don't want all the symptoms. I just want the ones that are limited to the chest.
Guys, so there are more.
Christian, you can talk.
Didn't make bad decisions.
Yeah. Gassan, you guys say it on the microphone. So what, number one, what is the most common respiratory presentation of acute histoplasmosis?
Pneumonia-like features? Pneumonia-like
You can have pneumonia for sure, but it's not the most common.
Flu-like.
Flu-like. Flu-like. Okay, so that's one. Flu-like. Then you mentioned pneumonia, acute pneumonia. That's good. What else can you get?
Chronic cavitary lesions.
You can have chronic pulmonary histoplasmosis that looks exactly like TB. What else?
Feeling bad?
So I didn't talk about this in my lecture, like other symptoms.
Well, I don't care. I want them too.
Lymphadenopathy. Bronchiectasis.
So Christian is saying that he didn't talk about the other syndromes in his lecture, so we're going to allow him to say what he thinks. Okay, go. Go for it.
Okay, so you can have the mediastinal complications.
Which
so
are
you can
good.
have a fibrosis mediastinitis.
You can have fibrosis mediastinitis.
And you can have in general like mediastinal lesions like granulomas and lymphadenopathy. So.
Mediastinal granulomatosis. So it's good, very good. Good, I like it. All right, so again, as I said, asymptomatic pulmonary histo, acute pulmonary histoplasmosis that goes from a flu-like to severe acute disseminated disease, ARDS picture. Chronic pulmonary histo, which looks like TB. You can have bronchiolithiasis. Actually, that's one that you guys didn't mention. Is that just granulomas? No, it's not a complications. It's like you have granulomas that erode into the airways, and they're all granulomas look like stones. So that's one. And you have granulomatous mediastinitis and fibrosis mediastinitis. Good. Lux. And we're going to do 2 more questions and stop. Okay, Lux.
HIV for 200.
HIV 200, okay. All right, so you have a patient with possible acute retroviral syndrome or acute HIV and a known exposure about 2 weeks ago. So how would you proceed to diagnose this patient? And I want you to explain the difference between the most commonly available diagnostic test for HIV. And what I want you to tell me is what is the window period for all of them.
Okay, if you have a patient with possible acute HIV syndrome, then you have to assume that probably he doesn't have antibodies, and you have to test for viral load to see the content of viral,
Okay, so
in his system.
That's number one answer, correct? So you want to send a viral load. Okay, so now tell me the difference between in terms of the window period for HIV viral load, 4th generation HIV test, and 3rd generation HIV test. That's what I want.
Okay, so the 4th gen, there's a 5th one, but there's no benefit versus the 4th one. But it's usually, so it's.
There's not a lot of difference in the window period between the 4th and the 5th. It's only the differentiation between HIV 1 and 2. So tell me the window period for 4th and 3rd.
So for 4th is between 3 to 4 weeks, so usually a month. And for 3rd, it's usually 6 and above. Some people say 8, but 6. You can diagnose it in 6 weeks, I think.
They're being quite conservative. I would say, and again, for most patients, I would say that's correct. But for 4th generation is between 18 to 21 days, more or less. If you want to be conservative, you can extend it to 1 month. But the 4th generation test, you should be able to detect antigen between 2 to 3 weeks. The 3rd generation, I agree, is between 4 to 6 weeks because you're only testing for antibodies. Okay? But I'll give you the points. Very good. And the last question for West.
History of medicine for 100 for West?
No.
You want to take that one?
Neutropenic fever.
Neutropenic fever 200. All right, so microbiologic agents more commonly isolated in patients with neutropenic fever and infection. It's very easy. So, tell me the examples because you may be wrong. Tell me.
That is great.
Tell me,
It's all the gut bacteria mostly, the oral.
what is the most common agent? So that's the wrong answer.
Pseudomonas.
No, San Luke's.
The most common? Enterococcus. The most common.
San Luke's, you want to take this one?
Enterococcus?
All right. No, so the answer that I want to actually is first of all, is bacteria. Number two is gram-positive bacteria is 60%. And as a matter of fact, staph epidermidis is the most commonly isolated. Now, the thing with this is that, remember, so if you read fever and neutropenia, the classic teaching from the 1970s and 80s was that gram-negative bacteria were the most common ones. However, we started to stick everyone and put chemoports in everyone and to put central lines in everyone, and we changed the epidemiology of that. So essentially, after the 1980s, 1990s, that changed, and gram-positive bacteria became the #1 isolated. Right now, there is actually a resurgence of gram-negative bacteria, and we are about 60-40. So 60% would have gram-positive, 40% would have gram-negative. But if you are asked the question of what are the most common bacteria isolated in patients with fever and neutropenia, is actually gram-positive. Now, the reason why we treat with monotherapy with anti-pseudomonal is because the most serious infections in these patients are due to gram-negative, particularly Pseudomonas. And that's why. And there's also some other things. It may be the case that gram-positive bacterium is only transient in these patients and stuff like that. But the most commonly isolated are gram-positive. Okay? Good. So, Marcelo, what's the score?
All right. Final score: St. Luke's 2150 and West 3400.
Oh, it was a bit off. Right. Good. So we won. Okay, guys. Thank you for coming to Jeopardy. Enjoy your weekend. Okay.